Hey there, welcome back to the new section on cardiology and cardiovascular system. In this particular topic, we are going to discuss on the coronary blood flow and a basic introduction to your ischemic heart disease. So this topic is going to be the basic for your future understanding on major disorders like chronic chest pain, that is chronic stable angina, unstable angina, and STEMI as well as STEMI, which are collectively called as ACS, acute coronary syndrome. But anyways, nevertheless, I have to tell before starting cardiology about one important thing. Apart from being an interesting topic, cardiology is also one of the most wonderful fields that has evidence-based practice. So in cardiology, the one thing that all cardiologists are concerned is all about the evidence. So where this evidence is coming from? It's coming from the trials. So for example, whenever you talk about something called a fractional flow reserve, so where I tell 0.80 is the cutoff for a normal fractional flow reserve. So less than that, you will go for a percutaneous coronary intervention. So where this data of 0.8 is coming from? So you have a lot of trials. For example, you have a DEFER trial, you have a FAME1, FAME2 trial. So these are the trials that are going to provide that data and going to tell you that probably this is going to be the cutoff, so beyond which you can do or below which you cannot do something. So and vice versa as well. So you need to know about the trial. So trials are not really important for exams unless until you are preparing for a NEET super specialty exam. The trials are not really going to be that important. But even at an undergrad level and even at an intern or a post-intern level, it's very, very important to know about these trials because we have to develop the habit of getting that evidence-based practice, and we have to know that there is a lot of research going on in the world, and that also gives an important view for the student that we have to do some research in the future when we become a practitioner. So what I've tried to do in this particular cardiology topic is the fact that I'm trying to integrate these trials as well. So when I'm going to start with a particular topic, for example, if I'm talking about a fractional flow reserve, I'll put a star on the side. So I'll write the evidences, that the trials that have been telling that important information about the fractional flow reserve, so that you can go and see later on if you really want it. So that's what I'm trying to experiment from this particular chapter on. So hope you will like it. But anyways, so without wasting much time, let us start with the chapter in the sense. So we're going to start with the coronary blood flow first. So what are the peculiarities of the coronary blood flow? So the first question that comes into everyone's mind about coronary blood flow is what percentage of cardiac output is actually taken up by the coronary blood flow. So it's 5%. That's going to be the answer. The 5% of the cardiac output is going to be spent on the coronary blood flow. And remember the fact that this is not fixed and it can be increased by 5 times during exercise, which means the cardiac output is also going to increase during exercise, and the coronary blood flow is also going to increase during exercise because during exercise it poses a huge demand on the myocardium to contract more. And apart from that, if you ask when does the coronary blood flow happen, so this is a common question from the undergrad level. So coronary blood flow is going to happen during both systole and diastole, contrary to the popular belief of an undergrad student that coronary blood flow is happening only during diastole. It's not the case. Coronary blood flow can happen during both systole as well as the diastole, because during systole there will be formation of something called as eddy currents. And how the coronary blood flows happen during diastole and how the coronary blood flow happens during systole through eddy currents, we'll be discussing subsequently in the coronary anatomy later on whenever we need it. But right now I'm not going to talk about it. But it's important to know that these eddy currents can be formed and that can contribute to the coronary flow during systole itself. But there will be a differential flow during systole and diastole. So for example, if you take the right coronary artery that is supplying the right ventricle and associated structures, 50% of the coronary blood flow will be contributed by systole and 50% will be contributed by diastole. If you take the left coronary circulation, only 30% will be contributed by the systole and 70% will be contributed by the diastole. So since we are mostly concerned with the left coronary circulation, so physiology textbooks take this value for granted that 70% of the left coronary flow happens during diastole. So they tend to give a relatively false statement that coronaries actually fill during diastole. So, but what is the reason why coronaries fill during diastole? Apart from the anatomy of the coronary ostium in the sinus of Valsalva, which we'll be discussing subsequently, it's also important to understand how the coronaries really fill and what are epicardial vessels. So for this, let me put an image. So this is the image I'm going to use throughout the cardiology for simpler understanding. So let us zoom in a little bit and see so what's going to happen really. So why these are called as epicardial coronary vessels? Because they are going to pass on the surface of the myocardium. So that is the epicardial surface. So these epicardial coronary vessels are basically three in number, the major epicardial coronary vessels. One is the right coronary artery, second is the left anterior descending artery, and third is the left circumflex artery. So left mainstem usually we do not put under the epicardial vessels, so which is on the top of the tree, but the RCA, LAD and LCX, that is left circumflex, all these three vessels are going to be the major epicardial vessels. So why they are called epicardial? Because they are on the surface of the heart. That's why they are called as epicardial vessels. And they are going to produce a blood flow or a blood supply to the heart in the direction of epicardium towards the endocardium. So if somebody asks you what is the direction of blood flow, it's going to be from the epicardium to endocardium. That's going to be the direction of blood flow. On the other hand, you also have to understand the fact that the heart is a blood-filled chamber and the endocardial surface we are talking about. So the deepest or the innermost surface is what we refer to as the endocardial surface. The endocardium can directly consume oxygen most of the times through the blood that is present in the chambers itself. And that gives rise to an important point that the subendocardial portion, that is just below the endocardium, is going to be the most distal portion from the blood flow, relatively speaking. Even though endocardium is the most distal portion to the blood flow, but still they can take up oxygen and they can consume oxygen directly from the blood that is present in the chambers itself. And from a functional point of view, the subendocardial portion is going to be the most distal portion for the blood that is flowing through the myocardium, and that's why this portion, the most distal portion, that is the subendocardial portion, is going to be the most vulnerable for ischemia. Of course, yes. And it's also important to understand the fact that these epicardial vessels are not going to offer any significant resistance to coronary blood flow, which means the blood is usually free flowing in the epicardial coronary vessels we're talking about. Then what are going to be the sites of resistance? So the site of resistance is usually the microvasculature, which I'm drawing right now, which are nothing but these penetrating vessels which I've shown here that are going from epicardium to endocardium, and these are going to be the predominant sites of resistance. So I can write that this microvasculature and not the epicardial vessels are going to be the sites of resistance as far as coronary blood flow is concerned. So talking about these epicardial vessels, what are these epicardial vessels? Remember, left mainstem typically will not come under this major epicardial vessel section, but there are three basic major epicardial vessels, that is the left anterior descending artery, then the left circumflex, then the right coronary artery. So these three are basically called as the major epicardial vessels. And whatever I've told you right now is very, very important in the setting of a stenosis, because what do you mean by stenosis in the first place? This is nothing but a narrowing of the coronary artery lumen or an epicardial vessel lumen. That's what we refer to as a stenosis. So whether the stenosis is hemodynamically significant or angiographically significant, and what are the cutoffs for that, we'll be discussing subsequently. But right now understand how the stenosis becomes significant. Stenosis means narrowing of the lumen. Narrowing of the lumen means by postural flow you're going to offer more resistance. When you're offering more resistance, there should be reduced flow, right? So that's why the vessels go for reduced flow and subsequent ischemia of the myocardium, and you can even result in a myocardial infarction over a period of time. So you have to understand the fact that epicardial vessels normally will not provide resistance, and in the setting of a stenosis, they are now providing resistance. Coupled with the microvascular resistance, the resistance is going to be too much and there will be a drastic drop in the coronary blood flow, and that is the reason for developing ischemia and infarction. Fine. And this understanding will also help in addressing our basic question, which we asked in the beginning itself: why left coronaries are filling during diastole predominantly and not during systole? So for that, we know a very simple fact from the first year itself, that left ventricle is thicker in comparison to the right ventricle, which is thinner, and left ventricle is predominantly supplied by the left coronary artery and its territory. And right ventricle is predominantly supplied by the right coronary artery and its territory. So we know a thicker left ventricle is going to produce a stronger contraction, so that the magnitude of contraction will be much higher with the left ventricle compared to the right ventricle. So if they contract heavily, they are going to compress the microvasculature more, and the resistance offered is also going to increase during the systole. So if the resistance is increased during systole dramatically in the left ventricle, in the left coronary artery territory, the flow is going to reduce, and that's why the left coronaries and the left ventricles are predominantly dependent on the diastole and not during the systole. And this is also one reason why the left ventricle and the left coronary circulation is the one that is maximally affected, the most commonly affected area in the setting of ischemia and infarction. And let us understand a simple thing. What happens in the setting of a tachycardia? So what really happens during tachycardia? Why tachycardia is a problem? Tachycardia itself is a problem because it's going to do something called a reduced diastolic time. That's why. That's the major problem in the setting of a tachycardia, any tachycardia for that matters. So read the Genong's physiology textbook where there will be a beautiful table where they have given at different heart rates what will be the length of the cardiac cycle, which will subsequently shorten, and because of that what will be the diastolic time, which also will take a huge hit and subsequently get shortened in the setting of a tachycardia. And that's the most important problem. And whenever you shorten the diastolic time, the coronary blood flow is going to decrease, especially in the left coronary artery compared to the right coronary artery. And the left coronary artery is going to suffer more than the right coronary artery. And subsequently, the left ventricle is going to be affected more than the right ventricle because left coronary territory is going to supply the left ventricle predominantly. And that is why the left ventricular zones are the ones that are very, very prone for ischemia and infarction even during the setting of tachycardia. Not only generally, even during tachycardia, that is the one that's most commonly affected. Apart from that, we have been talking about stenosis. Now, we'll be talking about what do you mean by angiographically significant stenosis or what do you mean by a hemodynamically significant stenosis. First of all, we have to know the basics of stenosis and its effect during rest and exercise. So then only you'll understand why the chest pain really happens and why your blood flow decreases dramatically during exercise. So first let us understand what do you mean by a significant stenosis and when the chest pain will happen in the first place. So the chest pain can happen during exertion if the stenosis exceeds this 70% cutoff. If the narrowing of the coronary lumen is beyond 70%, then you will get chest pain at exertion, especially if it's at the epicardial level. For left mainstem, it's a little different. It's 50% is the cutoff. But anyways, fine. In general, more than 70% stenosis will result in chest pain during exertion. But chest pain can happen at rest itself if your stenosis is beyond 90%. This is a danger zone. Now the chest pain can happen at rest itself. Okay. So what really happens during exercise so that you will get ischemia and chest pain? So why specifically during exercise? You might ask increased demand, but fine. So what is happening at the microvascular level? Let us see. So let me draw aorta. From aorta, you are going to get an epicardial coronary vessel, like right coronary artery for that matters. So this is the epicardial coronary vessel. This is the aorta, which I'm writing as AO. And now you're having the microvasculature. From the epicardial vessels, your microvasculature is going to split. And the same diagram, I'm going to use it multiple times. So I can reproduce again and again. Okay. So there is no stenosis now. So without stenosis, what will happen at rest? Nothing. The flow is normal. Everything is normal. No ischemia. What's going to happen during exercise? During exercise, one important thing that happens is this microvascular dilatation. And that's the most important thing that really happens. So why there should be a microvascular dilatation? Normally the microvasculature provides resistance. Now once the microvasculature dilates under the influence of your catecholamines, especially beta-2 receptors are going to vasodilate. So once you develop subsequent vasodilation, there will be more blood that's going to pool in the microvasculature because of dilatation and increased diameter of the vessels, there's going to be low resistance by Poiseuille's law. And because of the low resistance, there will be increased blood flow. And to produce this increased blood flow, the heart also has to do something. So they will produce more epicardial flow. So there will be small dilatation of the epicardial vessel, which is not really important in this understanding. So, but anyways, fine. So there's going to be more flow into the epicardial vessels because the cardiac output itself will increase and the systolic blood pressure itself will increase and the diastolic blood pressure also will increase to a great extent. So because of that, your flow through the epicardial vessels will be more And that flow is the one that is going to compensate for the microvascular dilatation, and that flow, increased flow due to increased cardiac output, is the one that's going to fill this dilated microvasculature, so that your myocardium that is actually now needing more blood is actually satisfied. So this is what is going to happen during normal exercise, and this kind of microvascular dilatation during exercise is what we refer to as hyperemia and hyperemic circulation. Now let us understand what's going to happen in the setting of a stenosis. So we're talking about non-stenotic physiological stage till now. Now we are going to the setting of a stenosis. So what's going to happen there? So let me draw this image multiple times because you're going to use the same image again and again. Okay. If I'm going to talk about a stenosis, means I can draw a angiographically significant lesion at this point in one of the epicardial coronaries or in the left mainstem, which is going to cause a severe flow limitation. But let us assume this stenosis is just more than 70%, but not more than 90%. So let us assume if it's more than 90%, they'll cause chest pain at rest itself. But if it's more than 70%, typically they'll cause chest pain during exertion only, but not during rest. So anyways, fine. So what will happen if it's a significant lesion, but not more than 90%, but just more than 70%, and what will happen at rest? During rest, whatever blood that is flowing across this stenosed vessel is enough to fill up this microvasculature, so that the myocardium will not go for ischemia and will not go for any sort of problem, and they will not be having chest pain. So they will be having reduced flow. There's no doubt about that. It's a flow limiting stenosis only, but the demand is not that high, and the microvasculature has not dilated so much to utilize more blood. That's why they don't have any problem. So at exertion, the things are going to be very different. During exertion, we know that the microvasculature is going to surely dilate. Why they dilate? Because they need to receive more blood, and they have to produce lesser resistance for more flow across the microvasculature, so that your myocardium will be taking off more oxygen and meet its demands when they are doing some extra work. So I can draw a dilated microvasculature here, and in the presence of a significantly stenosed epicardial vessel or any coronary vessel, the flow is not going to increase. Remember, if the flow does not increase, means this reduced flow will not be able to fill up the dilated microvasculature, which means the microvasculature will not be adequately filled, so that the myocardium cannot use sufficient oxygen for the same, and they can go for ischemia, and in worst case scenarios, they can even go for infarction. So that is why this stenosis is what we refer to as something called a flow limiting stenosis, which produces only a fixed coronary blood flow, or called as a fixed flow limiting stenosis. Remember, stenosis at the early stages, they will not be flow limiting, which means they can still alter the flows. Once it becomes extremely significant, the flow will become fixed. Whatever may be the case, they cannot increase the flow. So that's why during exertion, the demand is more, the microvasculature is dilated. So you cannot satisfy the demand as well because you're not increasing the flow. At the same time, you cannot fill up the dilated microvasculature because you're not producing sufficient flow. Fine. And that is going to be the basis of something called exercise stress test. So you're using something called a treadmill-based test. What is a treadmill-based test? You are basically asking the patient to exercise and finding out whether the patient is developing chest pain or any evidence of ischemia in the electrocardiogram. Usually, the electrocardiographic changes happen much before the clinical chest pain. That's the basis of what we use something called a treadmill test. So we are going to see the ST changes and ECG changes much before the onset of chest pain in the patient. Fine. So can you produce any other kind of stress using drugs instead of exercise? Which means there are some patients who cannot exercise. So that is there any alternative for them? Yes, of course. You have drugs that can produce similar kind of picture. For example, drugs like dipyramidol, adenosine, because dipyramidol is going to reduce the adenosine uptake by the endothelial cell, so that there will be more adenosine in the local area, so that they can produce vasodilatation. And adenosine, of course, can produce the same effect. And there is another analog of adenosine called regadenoson, which can also produce a similar effect. Currently in India, we use very commonly adenosine-based test. So what really adenosine does? All these drugs are basically going to produce microvascular dilatation, which means they are going to produce hyperemia, similar to what exercise does. Simple. So that's why patients who cannot exercise, you can produce hyperemia and microvascular dilatation selectively by giving these drugs. So that's why these drugs are used in the setting of a pharmacological stress test, which we'll be discussing subsequently in the later chapters. And apart from that, there are a lot of areas that we have to understand right now. So first we have something called this epicardial coronaries, which have to be assessed basically, including the left mainstem. Left mainstem classically will not come under the epicardial coronaries, but for understanding purpose, we can put that under the epicardial coronaries itself. Apart from that, one has a need to assess the microvascular circulation as well. Because microvascular dysfunction also has been proven to produce certain important problems in cardiology like INOCA and MINOCA, which we'll be discussing subsequently. So for example, there are a lot of cases who show ischemia, but in a coronary angiogram, the coronaries will be absolutely clean, which means there will be no plaque at all. So this is what we refer to as a clean coronaries. So whenever the patient is having evidence of ischemia in the setting of probably ECG change or probably an ischemic chest pain, but you do a coronary angiogram, absolutely normal, clean coronaries, you think about two entities. One is probably a vasospasm, which happens in the epicardial coronaries, or probably it could be a microvascular dysfunction or a microcirculatory dysfunction. So apart from significant stenosis of the epicardial vessels, which can be assessed by the coronary angiogram, there could be microvascular dysfunction, which actually cannot be assessed by coronary angiogram, can also produce certain problems in clinical cardiology like INOCA and MINOCA. So what do you mean by INOCA? This is nothing but ischemia with no obstructive coronary arteries or no obstructive coronary artery disease. What do you mean by MINOCA? It is nothing but myocardial infarction in the setting of no obstructive coronary artery disease. Myocardial infarction with no obstructive CAD. So this is what we call MINOCA. And this INOCA and MINOCA are typically thought to be due to microcirculatory dysfunction. So one has the need to assess the microcirculatory dysfunction as well. So microcirculatory dysfunction assessment is more important for the diagnosis of certain disorders, but rather than it will not be helpful in telling whether you need a PCA or not. So microcirculatory dysfunction cannot be treated with an intervention because they are very small vessels and they cannot be assessed by angiography in the first place. So, but there are ways and techniques to assess the microcirculatory dysfunction as well. So, what are the ways? So, one of the important ways to test this microcirculatory dysfunction is the IMR. So, that is what we refer to as something called index of microcirculatory resistance. There are a lot of ways to test for the IMR, which I will tell you subsequently. But right now, you have to know what you mean by IMR. IMR is nothing but index of microcirculatory or microvascular resistance. On the other hand, the epicardial coronaries can be assessed relatively easily, and the gold standard for that is coronary angiogram. But the common pitfall of the coronary angiogram is the fact that it can tell whether the lesion is angiographically significant or not, but they cannot tell whether the lesion is hemodynamically significant or not. So to tell whether the lesion is hemodynamically significant or not, you need to use certain indices. So like for example, we have something called a fractional flow reserve and we have something called the instantaneous wave-free ratio called as IFR. So FFR, IFR are two important values that you have to know which can actually assess the hemodynamic significance of an epicardial coronary lesion. In fact, the left mainstem lesion as well. So fine. First of all, we need to know what do you mean by this angiographic significance. So let us see the definitions. If the stenosis is more than 70% narrowing of the lumen, if it happens in the major epicardial, one or more of the major epicardial blood vessels, for example, like right coronary artery or left circumflex or left antedescending, that's considered to be angiographically significant. Or if the left mainstem lesion, we call it as LMS, or simply other words you can call it as left main coronary artery, also LMCA. If the LMCA stenosis is more than 50% in angiography, we call it as an angiographically significant lesion. But remember, angiographic significance is not always equivalent to functional significance or hemodynamic significance. So address the hemodynamic significance of a lesion, we use something called FFR and IFR, that is fractional flow reserve and instantaneous wave-free ratio. So remember, this FFR and IFR can be addressed during the setting of coronary angiogram itself. Whenever you see a lesion more than 50% and less than 90%, FFR is really helpful for guiding PCA, whether to do PCA or not. So that's why FFR is currently considered as the gold standard for guiding therapy, especially in patients who are having this gray area kind of a stenosis, guiding PCA as a therapy, which means less than 50% mostly won't have any issues, because that will not be functionally significant most of the times. More than 90% anyway, it will be functionally significant because there will be a significant stenosis and the patient will have chest pain at rest itself. Rest pain means it is significant only. 50 to 90% is the place where it can be significant hemodynamically or it may not be significant hemodynamically. First, let us see what you mean by FFR in the first place, fractional flow reserve. So the basis is very simple. So let us draw a simple image which we have already drawn in the past. So the coronaries, microcirculation and aorta. So this is going to be the aorta, this is going to be the epicardial coronaries, and this is going to be the microvasculature. And since I'm going to draw it again, I'll reproduce the image one more time. So let us assume both these patients are having some degree of stenosis. Let us say it is more than 50% but less than 90%, where the utility of FFR is maximum, which I'll be discussing subsequently. So what you're really going to do initially when you are putting a coronary artery catheter, so first you go into the aorta, then enter the coronary ostium and into the coronary vessels, and you put a dye and see a stenosis over there. And once you see a stenosis, what you're going to do is you're going to push the catheter distally, and you're going to have a transducer over there, and you're going to measure the pressure in the distal zone, that is distal pressure, called as PD. Typically, this distal pressure will be an index of what is the pressure in the distal layer, that is in the microcirculation. And proximal pressure also you can measure in the form of aortic pressure, and that's going to be the PA. And if you don't do anything, just measure the PD bar PA, that is called as a baseline PD bar PA, and that doesn't have any much value. And that must be ideally equal to 1, basically because the proximal pressure must be equal to distal pressure, so that there is equal pressure. Ideally, it must be equal to 1. That's a baseline pressure. But during the times of stenosis, it might be different. That doesn't matter. But what is really important for us is during the times of exercise, you have to reproduce exercise. How you are going to reproduce exercise? By giving something called adenosine or a reg adenosine. Typically, we use adenosine for this purpose. Can use dipyramidol also, but we are moving away from dipyramidol and we are using adenosine very commonly nowadays. When you give adenosine, what really happens? You are going to reproduce what exercise is going to do, that is microvascular dilatation and microcirculatory dilatation. That's what you're going to produce. So if you produce a microvascular dilatation, and for that matter, your coronary catheter is going to be in the same place. Now you will be still measuring the PDPA. The PA will not change anyways because you are selectively producing microvascular dilatation with adenosine. But the PD is going to drop dramatically because the microvascular system has dilated, and only if the blood flow is adequate and if it fills adequately, then you will be having sufficient pressure that is maintained. Suppose if the stenosis is limiting the blood flow in a very significant way, the microvasculature will not be filled adequately and they will be empty, so that the pressure will not increase. The PD will drop dramatically. So which means if you measure PD bar PA after giving adenosine, that is once you produce hyperemia, which means you are measuring the hyperemic PD bar PA, is what we refer to as something called a FFR. So hyperemic PD bar PA is what is called as fractional flow reserve. And if fractional flow reserve is less than or equal to 80%, that is 0.80, that is considered to be hemodynamically significant stenosis, and you are going to take them for PCA, no matter what. That is stenting, layman terms, percutaneous coronary intervention. So who has given the cutoff of probably 0.80? As I told you, cardiology is something like an evidence-based practice. So you need to have some trial backup for who told that that 0.80 is the basis of guiding the PCI. So we have two important trials, that is FAME-1 and FAME-2 trials, which told that cutoff and clearly proved that this value is going to guide you the PCI, and at the same time they have showed a good benefit in terms of mortality and long-term survival. And there is an old trial called as DEFER trial. In fact, the DEFER trial is the first trial which proved that not all angiographically significant lesions should be taken for PCI. So that's why that also should be mentioned here. And DEFER trial is one of the very old trials And DEFA trials used a cutoff of 75%, that is 0.75. But FAME 1 and 2 clearly proved that 80% is a much better cutoff compared to 75%. So let us take this certain statistics and see why this is important. So remember, if the stenosis is less than 50%, and the percentage of patients who is going to have a FFR of less than 0.80 is going to be almost nearly 0%. No patient with stenosis of less than 50% usually will have a FFR of less than 0.80 unless and until there is another coexisting condition like severe anemia or probably LVH or something else. If the stenosis is in the range of 50 to 70%, 35% tend to have an FFR of less than 0.80, which means it doesn't mean that if the stenosis is less than 70%, you should not do a PCA. Still, they can be angiographically significant. Still, these patients will be taken for PCA. That's the important. That underscores the importance of FFR. And if the stenosis is in the range of 70 to 90%, and the percentage of patients who will have a hemodynamic significant stenosis or FFR less than 0.80 is approximately 80%. It's a higher number. Of course, it's expected. But what you are really seeing is only 80% of the patients will be needing PCA. And still, there are 20% of the patients, despite having a stenosis more than 70%, they are not having any hemodynamic significance or functional significance. So, in these 20% of patients who are having FFR more than 0.80, even if the stenosis is more than 70%, you need not do a PCA and you can defer the PCA in these patients and you can treat just medically. And if the stenosis is more than 90%, almost all the patients will be having FFR of less than or equal to 0.80. So all these patients will be taken for PCA. Clear? So do the FFR. That's the final take-home point. So remember the fact the FFR is most useful in patients who are having stenosis in the range of 50 to 90%. More than 90, anyway, it will be significant. So we are going to do a PCA. Less than 50%, anyway, they will be non-significant. You really do not need to do a PCA in those patients. 50 to 90% is the place where FFR is most helpful. And the final take-home point, FFR less than or equal to 0.80, do a PCA. FFR more than 0.80, need not do a PCA, just treat medically. And we have another, index that is called instantaneous wave-free ratio. Is there any reason to have another index? Yes, of course, because we know FFR is actually measured after giving adenosine. Once you produce hyperemic circulation, then only you can find out the FFR. But adenosine cannot be used in certain situations and certain settings. For example, adenosine has a lot of side effects, like bronchoconstriction being the most important side effect. It cannot be used in the setting of severe bronchial asthma or COPD, where it can even produce severe bronchospasm, respiratory failure, and sudden death. So in areas where you cannot use adenosine, or in areas where adenosine is contraindicated because of the pre-existing conditions, you have to have an index which does not use adenosine, but still give some idea about whether to do a PCA or not. So that is where your instantaneous wave-free ratio becomes really important. So instantaneous wave-free ratio, we are going to measure the PDPA only, but you don't need hyperemia, which means you don't need adenosine here. But how will you tell whether this is really important or not, whether this is really significant or not? Because we are going to measure the PDPA not randomly. We are going to measure at a specific point in the pulse waveform called as a wave-free period. So wave-free period is a very specific area in the diastolic pulse wave. So where your coronary blood flow will be at its maximum in the entire cardiac cycle. And at the same time, there will be absolutely no competing waves from any of the other systemic vessels like aorta. No competing waveforms. So it's all about the coronary blood flow and the coronary circulation only. So that's what we called as a wave-free period. So to understand where is the wave-free period, even though it's not important for exams at any cost, because the machines are going to do that, not us. So you can see this image. So this image clearly tells that there is an area where your coronary blood flow will be at its maximum and there is no competing waves. You can see here, there is absolutely no competing waves from other systemic vessels. So that's what we refer to as a wave-free period. And you can extrapolate, this is an experimental data, and you can extrapolate into the simple pulse waveform. So in the pulse waveform, this portion corresponds to what we have experimentally discovered already. That's the wave-free period we're talking about. And during this particular period, if you find out the PD bar PA, that becomes really significant like that of FFR that we have already known. So is there any cutoffs for that instantaneous wave-free ratio? Yes. IFR values of more than 0.94 is considered to be very, non-significant, and you can defer the PCA in this setting. IFR values of less than or equal to 0.86 is considered to be hemodynamically very significant. You can take IFR of less than 0.86 as FFR of less than 0.80, and you have to do a PCA in this setting. Similarly, IFR in the range of 0.86 to 0.94 is a gray zone. So here, whether to do PCA or not depends on your personal expertise, or maybe depending on the patient's comorbid conditions, how much risk he's having for future cardiovascular disease or future death because of cardiovascular disease, or what is the status of the patient currently. Is he very symptomatic? So depending on a lot of other factors, you can do a PCA here or not do a PCA in the same sitting. So what are the trials that have told you that IFR is really significant, and what are the basis of these cutoffs as well? So you had 3 trials for that. One is called the DEFINE FLARE study, which is going to be the most important of all. Then we have the IFR Swedish Heart. It's done in Sweden. That's why it's called a Swedish Heart. And we have an ADVICE study, which is a very old one. So it's the first thing to tell about the IFR. But anyways, this DEFINE FLARE is the one that clearly defined the utility of IFR in clinical practice in patients where adenosine cannot be used. And after all these things, we have certain indices that can detect the microvascular dysfunction. We know that. So one index we discussed already which can detect the microvascular dysfunction is the IMR, that is index of microvascular resistance. How we are going to find out the microvascular resistance is basically by using a formula that is called as PD multiplied by transit time. That is nothing but the coronary blood flow. The transit time, if I use that word, it always means coronary blood flow. Transit time during hyperemic states. Which means to find out this IMR, you need to produce hyperemia, which means you need adenosine here also. Fine. So whenever I call transit time, remember it means simply a coronary blood flow that I am talking about. Because the amount of coronary blood flow will be proportional to the transit time. So by using the transit time of how much time it takes for the blood to move from one area to another area will be proportionally equal to the coronary blood flow. So that can be used as an index of coronary blood flow. So it's nothing but the coronary blood flow, that's what you're talking about. So this is the formula for IMR. IMR is not of that much utility, but anyways, there is another thing that is of a little utility, that is called the CFR. So what do you mean by the CFR? That is coronary flow reserve. So coronary flow reserve assesses the entire coronary tree. It's not specific for the epicardial vessels, nor it's not specific for the microvascular problems. So it's going to assess the entire coronary tree for that matters. So how can you measure the CFR? CFR can be measured through invasive techniques as well as through some non-invasive techniques. Invasively, you can measure using coronary angiogram itself, or you can measure using a color Doppler. If you measure using a color Doppler using the velocity of the blood flow, then it will be called as coronary flow velocity reserve. That's called a CFVR. That's simply not called a coronary flow reserve. That will be called as a coronary flow velocity reserve. That's CFVR. If you are going to assess using a non-invasive technique, so non-invasive technique can be either a PET, positron emission tomography, or a SPECT, or even you can utilize a cardiac MRI, or you can use something called a contrast echocardiography. Contrast echocardiography, right? So all these terms might be very new to you, but we will be discussing subsequently in the subsequent chapters. Don't worry about that. So you might be asking, Doppler is also non-invasive technique. No. The Doppler that we are seeing here is invasive. During the coronary angiogram, intracoronary artery transducer will be there. Through that only we are finding out the transit time on the coronary blood flow. So that's why it's actually an invasive one. It's not a non-invasive one. Fine. So we have different techniques to assess the CFR. And what is the formula for CFR? To find out the CFR, you have a very important formula, that is coronary blood flow at rest. I can write as a transit time at rest because both are equal, divided by transit time or coronary blood flow during hyperemia, which means for assessing the CFR also you need to produce hyperemia, which means you need adenosine. The only value or only index which you have seen till now that does not use adenosine is IFR, that is instantaneous wave-free ratio. CFR also needs adenosine to be used and it needs hyperemia to be produced. That's all. Is there any value to tell that CFR is significant? Yes, of course. CFR of less than 2 is considered to be significant. Even though it assesses the entire coronary tree, CFR less than 2 usually tells there is some microcirculatory dysfunction. That's the idea. CFR of more than 2 means it's non-significant, which means the microvasculature is okay. So, and I can plot all these 4 values in a chart and I can tell what we are going to think about with each and every value. So, FFR less than or equal to 0.8 always means there is some functionally significant stenosis, which means epicardial vessels are having some major issue and that they are having a functionally flow limiting stenosis. And in this setting, if the CFR is more than 2, means you don't have any microcirculatory dysfunction. So the microvasculature is basically okay, no problem. Is that going to change the treatment? No. So PCI has to be done here because there is a hemodynamically significant flow limiting stenosis there in the epicardial vessel, one of the major epicardial vessels. So CFR doesn't have any role here. In fact, it doesn't have any role to dictate a PCI whether to use it or not. It's always the FFR. You have to be very clear about that. So let us see the second scenario where your FFR is less than or equal to 0.8, which clearly tells there is some major flow limiting stenosis in the one of the major epicardial vessels, and CFR of less than 2, which also tells the fact that there is some problem in the microvasculature. So there is some microvascular dysfunction as well. So again, it's not going to change the treatment. You're going to do a PCI in this setting because there is some hemodynamically significant flow limiting stenosis in the one of the major epicardial vessels. So third scenario, FFR more than 0.8 and CFR more than 2. So in this setting, you can see that the epicardial vessels are not having any hemodynamically or functionally significant flow limiting stenosis. And at the same time, there is no problem in the microvascular circulation also. So whether we'll do a PCI or not, I'm not mad to do a PCI or absolutely I'll not do a PCI because the epicardial vessels are basically okay. They're not having any significant flow limiting stenosis. Fourth scenario, this is very important for your understanding, especially FFR more than 0.8, but CFR is less than 2. Here once again, the epicardial vessels are not having any hemodynamically significant flow limiting lesion, so that you don't do a PCI here, but you can see there is some element of microvascular dysfunction. There is a microvascular dysfunction for sure. Whether I can do a PCI in this setting or not, my answer will be a resounding no, because doing a PCI is not going to help microvascular dysfunction in the first place. And once again, you can see that FFR is more than 0.8, which means there is no hemodynamically or functionally significant stenosis here. So PCI is not going to help in any way. So microvascular dysfunction cannot be improved by opening up an epicardial coronary vessel, which you have discussed already clearly. So microvascular dysfunction can be treated typically medically. For example, ACE inhibitors can improve the endothelial dysfunction to an extent, but PCI definitely is not going to help. Or for that matter, any other intervention like even CABG, coronary bypass grafting, is not going to help you in this setting. But this particular setting will be helpful in identifying certain disorders like INOCA and MINOCA. So what do you mean by INOCA and MINOCA? INOCA stands for ischemia with no obstructive coronary artery disease, and MINOCA stands for myocardial infarction with no obstructive coronary artery disease. And of course, we know both these disorders are due to microvascular or microcirculatory dysfunction only. So how we are going to diagnose these disorders? Basically, these patients will be presenting to you with ischemic features. Like for example, clinically, they can present with chest pain, which is a feature of ischemia. They can come with investigational problems, like they might have problems in the ECG showing some STD changes suggestive of ischemia, or they might have some echocardiographic abnormalities, or they might have even troponin positivity. But if you take these patients for coronary angiogram to the cath lab, they'll be completely normal, clean coronaries, no problem at all. So what are the differential diagnoses in this setting? You have vasospasm, you have myocarditis, you have Takotsubo cardiomyopathy, you have cocaine intoxication, which can produce similar picture. You can even have this INOCA and MINOCA. So there are multiple differential diagnoses. How you diagnose, how you pick up this INOCA and MINOCA? By confirming that the patient is having a abnormal CFR or a IMR. Clear? So you have to prove that these patients are having microvascular or microcirculatory dysfunction. Then only you can diagnose INOCA and MINOCA. Vasospasm is usually a diagnosis of exclusion, but typically you have some gold standard investigations like provocation test, ergonomin provocation test, or acetylcholine provocation, which we'll be discussing subsequently. Myocarditis, gold standard endomyocardial biopsy, which you're not going to do routinely. For diagnosis of cocaine poisoning, you need just some history, that's all. For diagnosing Takotsubo cardiomyopathy, it's a constellation of many features. History of emotional outburst, then followed by patient presenting with more of a heart failure-like picture. Then patient is having the typical, octopus jar-like heart. That is what we refer to as the Takotsubo. That's apical ballooning, along with the clean coronary. So all this constellation of features is going to tell the diagnosis of Takotsubo. But on the other hand, Minoka and Inoka can be diagnosed only by showing or proving the microvascular and microcirculatory dysfunction, because Inoka and Minoka are disorders which are very commonly recognized nowadays in increasing numbers because of our awareness right now, and it's very common in the younger females especially. So you should not tend to miss these disorders as well. So let us make a summary of whatever we have learned till now. So we learned 4 values, isn't it? One is the FFR, next is the IFR, next is the IMR, then is the CFR, coronary flow reserve. First of all, we need to know whether they can assess the epicardial coronary vessels or not. FFR, yes. IFR, yes. IMR, definitely no. CFR, to an extent, yes. Even though it's very important for microvascular dysfunction, it can also tell you the status of epicardial vessels to an extent. Whether they can tell microvascular dysfunction or not, IFR, definitely no. FFR, definitely no. IMR, surely yes. CFR, surely yes. So we have 2 sets of investigations, or 2 investigations that will tell you the status of epicardial vessels, which is the gold standard, FFR and IFR, and 2 investigations which can tell the status of microcirculatory dysfunction, that is IMR and CFR, as simple as that. And whether you need to produce hyperemia or not in this setting, which means indirectly I'm asking whether you need to use adenosine or not. You know that for FFR you need hyperemia, and IMR you need hyperemia, and CFR you need hyperemia, but you know for measuring IFR, instantaneous wave-free ratio, you don't need hyperemia to be produced or adenosine to be used. In fact, the only index that does not depend on hyperemia and adenosine use is IFR, which I have discussed already. So let us move on and discuss regarding ischemic heart disease and its basics, because this is a basic introductory video. Let us see the classification first. So IHD is divided into 2. One is called a chronic angina, and second one is the acute coronary syndrome. What is the basic difference between chronic angina, or probably a chronic stable angina, versus an acute coronary syndrome? So let us take chronic stable angina on the left hand. So now this chronic stable angina is going to have a stable plaque, no plaque rupture, and apart from that, they are not going to leak out any content, and because of that, they are not going to produce any thrombus. So stable plaque, no plaque rupture, no thrombus. And because of that, they will be not having any biomarker elevation, no dynamic changes in the ECG, and at the same time, they're going to have a fixed obstruction only. The obstruction is not going to increase over a period of time. But anyways, the 3 most important points are stable plaque, no rupture, and no thrombus formation. On the other hand, if you take ACS, it's going to be completely different. ACS means unstable plaque, there is a plaque rupture, and there is a thrombus formation. Biomarkers may be elevated, which we'll be discussing subsequently, and at the same time, you might be having infarction and you might be having this dynamicity, which means the ischemia might progress over a period of time, or the obstruction might increase over a period of time. There is nothing fixed or stable in the setting of an ACS, acute coronary syndrome. That's why it's an emergency. So let us see the types now. As far as the chronic angina is concerned, the classic is the chronic stable angina. That's classic. Chronic stable angina. Second, we have something called a variant angina, or we can call it as a vasospastic or a Prinzmetal angina. Then third, we have an INOCA, that is ischemia with no obstructive coronary artery disease. So what is the problem in the setting of a chronic stable angina? Chronic stable angina basically is due to problem in the epicardial coronary vessels, which are typically affected with atherosclerosis and resulting stenosis. That's the problem with the chronic stable angina. On the other hand, if you take the variant or vasospastic angina, here again the problem will be in the epicardial coronaries only. But here the problem is not But on the other hand, if you take a INOCA, that is ischemia with no obstructive coronary arteries, it's not the problem of epicardial coronaries. Even if you have some stenosis of epicardial coronaries, it will not be functionally significant. But here the main problem is going to be microcirculatory or microvascular dysfunction. That's the problem here, producing chronic chest pain. On the other hand, ACS can be divided into something called an unstable angina, NSTEMI, STEMI, and finally you have something called a MINOCA, that is myocardial infarction with no obstructive coronary artery disease. Unstable angina, STEMI, NSTEMI, all these three things are due to problems in the epicardial coronaries. There are many different types of MI, which we'll be discussing subsequently. We have something called a universal definition of MI, where they have types of MI in that. So we have in the next chapter for that. On the other hand, if you take the MINOCA, myocardial infarction with no obstructive coronary artery disease, of course we know it is not due to problem in the epicardial coronaries. It is a microvascular or microcirculatory dysfunction. So in short, if you want to tell what is unstable angina, it's the earliest phase of plaque rupture and thrombus, where the thrombus will not be occluding the vessel completely, and at the same time it's not sufficient enough ischemia to produce an infarction. So the biomarkers will be normal. That's the most important feature of an unstable angina. On the other hand, if you take a STEMI and a NSTEMI, here the thrombus formation is so significant that there will be an infarct generation in that area, so which means there will be a troponin elevation. So the biomarker elevation is the one that differentiates the NSTEMI, STEMI versus unstable angina. Each and every of these single disorders has to be discussed in a great depth and detail. But for now, let us leave aside the common disorders, because discussion of common disorders needs separate chapters to discuss about them. So we're not going to discuss here because this is an introductory video. I said that multiple times. So let us start with the uncommon disorders, rare disorders first. So for that matters, we have INOCA and MINOCA, which are rare disorders which are only coming up in clinical practice right now in the last 1 or 2 decades. Then we have the vasospastic variant or Prinzmetal angina, which is very rare traditionally. So let us start with the discussion on vasospastic angina. Of course, we know the Prinzmetal angina is basically due to vasospasm of the epicardial coronary vessels, and most common vessel that is affected is the right coronary artery followed by left antidescending artery, even though vasospasm of multiple vessels simultaneously in susceptible individuals is not very uncommon. Now, if you see, when does this vasospasm happen? This vasospasm typically happens during midnight, around 12 to 1 a.m. up to morning 8 a.m., where the counter-regulatory hormones like catecholamines will be usually maximum. And remember, vasospasm does not happen in all the individuals. It happens only in susceptible individuals. And what are the risk factors for developing vasospasm and subsequent vasospastic angina? Of course, the most important clinically relevant risk factor is going to be the smoking, and majority of the patients who are having Prinzmetal angina will be elderly, having age 50, 60, and they will be heavy smokers. And apart from that, there have been a lot of risk factors that have been suggested, like migraine, cold exposure, Raynaud's phenomenon, hyperventilation, and usage of certain drugs, especially chemotherapy drugs like cyclophosphamide and 5-fluorouracil. And if you ask me for exams, from exam point of view, what are the 2 risk factors that are really important? That is smoking and hyperventilation. Multiple times asked questions. And how they are going to present. So clinical features will be that of ACS most of the time. So they're going to present with angina at rest. Remember, a chronic stable angina will present with angina during exertion, but whereas Prinzmetal angina is going to present with angina at rest only. So angina at rest is one of the important features of acute coronary syndrome. Please understand, even though this is not an ACS, because it's unrelated to acute coronary syndrome as of now. But anyways, so this is a completely different entity. So they're going to present with angina at rest. And if you take an ECG in this guys, there might be some changes. Like for example, an ST elevation might be seen, which is quite common. And usually it will be transient and reversible. Once the vasospasm is relieved, the ST elevations also will be relieved. Troponins, absolutely variable. It can be positive or it can be negative, which means it can be elevated or it can be normal completely. So it is unreliable. So depending on the severity of vasospasm, you can form an infarct that can elevate the troponins, or you may not form an infarct. That depends. What are the complications, by the way? So they can result in myocardial infarction, which means if the vasospasm is severe enough, they can elevate the troponins, resulting in a myocardial infarction and acute coronary syndrome really itself. Or they can produce arrhythmias like VT and VF because sudden ischemia, formation of re-entry circuits in the ventricles, development of ventricular tachycardia and ventricular fibrillation. And they can develop AV blocks because right coronary artery supplies SA node as well as the AV node primarily, so they can result in development of AV blocks. And because of all these problems, they can develop sudden cardiac death as well. So which means vasospastic angina is not a benign condition. It can result in sudden cardiac death also. So you have to take it a little seriously. So if you want to do investigations, what are the investigations you can do? Of course, the coronary angiogram is going to be the gold standard. And most of the time, you're going to have a normal coronary angiogram, which is what we refer to as something called like clean coronaries. But remember, this is only theoretical. Majority of these patients, as I told you, who are suffering from vasospastic angina will be elderly patients. They will be having some amount of atherosclerosis. But if they have a stenotic lesion, if they have atherosclerosis, it should not be hemodynamically significant, which means FFR should be more than 0.8. That's the idea. So, and there is an interesting theory which tells you that the vasospasm itself is due to atherosclerosis only. But this is not accepted right now, but this is an interesting theory which you can remember. So that theory tells that majority of the patients are old age and they have atherosclerosis. And they tell this plaque is neither unstable nor stable, which means it's somewhere in between. Occasionally, it might release some contents into the bloodstream. So because of that, there might be local platelet activation. Because this plaque contents, once it's released, they might activate the platelets locally. And these activated platelets will produce thromboxane A2. And because of that, there can be a local vasospasm. And this is a very interesting theory, but even though it is discarded, but this is quite interesting. That's why I told you. Apart from coronary angiogramic depiction of non-hemodynamically significant stenosis, it's also important to note that sometimes you can see the actual vasospasms in the coronary circulation. And if you want to depict those vasospasms, you have certain provocation tests. Even though these provocation tests are no longer performed in clinical practice, it's important to know their names at least. You have two provocation tests. One is called the standard or classic ergonovin provocation test, which typically uses a dose of 0.5 to 0.2 milligram intravenous ergonovin. Or you can use acetylcholine provocation test, where we use serial increasing doses of 10, 25, 50 and 100 microgram of acetylcholine. But here we'll be using intracoronary acetylcholine. So patients who develop vasospasm at very low dose of acetylcholine are known to have vasospastic angina, especially in the right clinical setting. Cardiology is always something you have to assess based on the clinical setting that you're dealing with. You should not take it as for granted just because of one value is abnormal or one thing is showing a positive result. So it should be a constellation of symptoms, signs, as well as the investigatory findings. Fine. Apart from that, if you're going to do a stress test, you're talking about nuclear stress test or a ECG-based stress test. So 1/3 will test negative, 1/3 might show ST depressions, 1/3 during stress test might show ST elevation, which means stress test is completely unreliable once again. The gold standard is again coronary angiogram only in the right context and appropriate clinical context. And how we are going to treat these patients? Of course, they should not smoke. Smoking is considered to be one of the important risk factors. They should completely stop smoking. And do not use aspirin for these patients because aspirin typically tries to reduce the prostaglandin I2 synthesis, that is prostacyclin synthesis from the endothelium, so that you might be resulting in more vasospasm. So do not use aspirin as much as possible. And non-selective beta blockers should be avoided. If you use a non-selective beta blocker, they can block the beta 2, which is important for vasodilation. So that might augment the vasospasm. At the same time, if you block both beta 1 and beta 2, they might result in unopposed alpha stimulation. If there is an unopposed alpha stimulation, there is more chance of getting vasospasm. So do not use aspirin, do not use non-selective beta blockers, and do not ask the patient to smoke. So stop smoking. So what are the drugs that you can prefer? Of course, I'm going to use some standard angina therapy like calcium channel blockers, nitrates, prazosin, alpha blockers, and nicorandil. Nicorandil also works on the potassium ATP channels, even though it has a dual mechanism of action, which we will be discussing subsequently. It works on the potassium ATP channels, causing hyperpolarization and lesser calcium entry, causing vasodilation of the coronary vessels. It's an anti-anginal drug. Suppose if the patient has arrhythmic episode or recurrent arrhythmic episodes, then ICD may be utilized for secondary prevention in the setting of persistent ischemia or proven VDVF. So you can use implantable cardioverter defibrillator. This is going to be the therapy for vasospastic or variant angina. So now let us discuss on the other uncommon disorders, that is INOCA. And MINOCA I'm not going to discuss because difference between INOCA and MINOCA is very simple. Troponin elevation with a similar feature MINOCA. If there is no troponin elevation, no infarct, it is INOCA, that's all. Typically INOCA also presents with chronic chest pain. And typically this chest pain will be ischemic, which means you are satisfying a clinical criteria. Then some non-invasive investigations may also show ischemia. So there will be evidence of ischemia going on in the non-invasive investigations. Like for example, ECG may show STD changes, that is ST depression and T-wave inversion, which are suggestive of ischemia. Or echocardiogram can show some abnormality, or perfusion scans can show loss of perfusion in a particular myocardial area or poor perfusion to a particular myocardial area. So non-invasive investigations are showing some problem. Evidence of ischemia is there. But if you do a coronary angiogram, once again you will expect a clean coronaries, which means there will be a normal coronary or a clean coronary. This is from theoretical point of view, but practically you might see a stenotic lesion, which means if there is a stenotic lesion, it will be hemodynamically non-significant. That is, FFR will be more than 0.8, as we discussed already. On the other hand, how you are going to treat these patients? Treatment of these patients will be typically based on medical therapy only. So you are going to use ACE inhibitors and statins, which can improve the endothelial dysfunction. At the same time, you are going to use additionally standard anti-anginal therapy like vasodilators, what I already told, like calcium channel blockers, nicorandil, and nitrates. So this anti-anginal therapy can be used along with that. And remember the fact, this chronic chest pain that typically happens during exertion is not due to epicardial coronary vessel problem. In the setting of INOCA, it is due to microvascular dysfunction. So what do you mean by that? So what exactly happens there? So there is no consensus regarding that, but probably it is due to poor dilation of the microvascular circulation, because during exercise, the microvasculature should dilate adequately. So to receive more blood from the epicardial vessels, so that will be given to the working myocardium during exercise. So if the microvasculature does not dilate properly, there will be persistent high resistance in the microvasculature, resulting in poor perfusion to the myocardial cells. So resulting in ischemia and development of chest pain. If it's severe enough, and if they are going to develop an infarct, if they are severe enough, the same INOCA, if it is severe enough, and if they are developing an infarct, which means ischemic troponin elevation, is what we refer to as a myocardial infarction. In this setting, we will be calling it as a MINOCA, that is myocardial infarction with no obstructive coronary artery disease. That's all, as simple as that. Let us move on to the basis of common ischemic heart disease. So we have discussed the uncommon ischemic heart disease, but we are going to the common ischemic heart disease now. So, and we are going to discuss only the basics in this video. Like for example, a chronic stable angina, I'm going to write as CSA here. Or typically currently we call it as a chronic cardiac ischemia. So that's also a right name. So let me put the old name, chronic stable angina, to avoid confusion. Then we have unstable angina. Then we have a NSTEMI, that is non-ST elevation myocardial infarction. Then we have a STEMI, that is ST elevation myocardial infarction. So what are the basic differences between them? So let me put a common image for all these things. So I'm going to draw the epicardial coronary vessels. I'm going to use the same image for all this. So I'm going to use the same vessel and the same atherosclerotic plaque for all the 4 conditions. As we know already, all these 4 disorders are due to problems of the epicardial coronary vessels, and all these 4 disorders are most commonly due to atherosclerosis. I am telling most commonly due to atherosclerosis, but I am not telling it is only due to atherosclerosis. And there is a plaque there, as I shown you. And let us put some headings. For example, what will be the nature of the plaque, whether it is stable or not? Is there any plaque rupture happening? What will be the clinical characteristics of angina in these patients? Is there any flow limiting stenosis happening in these settings? Is there any infarct that is happening? Is there any biomarker elevation? What will be the status of troponins? And what will be the electrocardiogram typically? So in the setting of a chronic stable angina, the plaque is going to be stable, and that's a defining feature of a chronic stable angina. So the plaque is stable, that's all. So of course, because it's a stable plaque, there is no rupture, and they are not leaking out any contents into the bloodstream, and angina typically happens only during exertion, and there will be no resting angina. And flow limiting stenosis may or may not be there, doesn't matter. We have to find out the FFR in coronary angiogram. Infarct, definitely no. Troponins normal, ECG can be normal, or they can have some baseline STT changes. But these STT changes will be non-progressive. They will not progress. That's the most important point. Even if you take serial ECGs in these patients, they will not be having any progression. In fact, chronic stable angina will have a fixed obstruction and a fixed pain, which we'll be discussing subsequently. That's a characteristic feature. And you have some sufficient time duration also. Only after 2 months, you can make a diagnosis of a chronic stable angina. Before 2 months, you cannot make a diagnosis of chronic stable angina, which we'll be discussing once again subsequently. So what about the diagnosis of unstable angina? In an unstable angina, definitely there is some leakage of plaque contents. Because the leakage of the plaque contents, there is development of thrombus. However, but this thrombus, of course it is flow limiting, will not be severe enough to produce an infarct, and there will be no infarct. That's the idea. So it's somewhere in between your chronic stable angina and a myocardial infarction, unstable angina, theoretically speaking. Here the plaque is surely unstable, no doubt about that. Rupture, yes, that's why you are having a thrombus formation. Angina, typically they will have resting angina, but unstable angina can sometimes present with a spectrum of clinical features like crescendo angina and many other stuff, which we'll be discussing subsequently. We have a separate Braunwald classification for that. And is it flow limiting? Of course it is flow limiting without a doubt. And in fact, no, it's not serious enough or severe enough to produce an infarct. Troponin elevation, no, because there is no infarct and it will be normal only. And ECG can be normal or can be abnormal, and they can show STT changes. But more importantly, these STT changes can be progressive, which means there can be dynamicity. They can change over a period of time. And in the setting of NST elevation myocardial infarction, the plaque is seriously unstable, which means it's a little bit an extrapolation of a unstable angina, which means you can see NSTEMI as the next stage of unstable angina. So where the plaque has become even more unstable, releasing more contents, producing more significant stenosis, but not a complete occlusion, by the way. And the stenosis is severe enough to produce an infarct, but not a total occlusion, not a transmural infarct. Only subendocardial portion will go for ischemia in this setting, and there will be multiple infarctions also that might happen, but it's not a transmural infarction, it's not a complete occlusion as well. So I can write here the plaque is once again unstable without a doubt. There will be rupture, and of course there will be a thrombus formation. And definitely they will come with anginitis because it's a significantly flow limiting obstruction. And infarct, yes, for sure it is there, and troponins will surely be elevated because there is an infarct, and ECG can be normal or can be abnormal, and they can show some STT changes, and of course they will be most of the times progressive in nature, and there can be a lot of variations, but of course there will be progressive STT changes. And coming to the STEMI, in the STEMI, the plaque rupture is serious and it's causing leakage of almost all the contents. That's the idea, and it's a complete occlusion of the vessel by forming a thrombus in the entire lumen of the vessel. So it's full occlusion, 100% total occlusion. So here, of course, the plaque is unstable without a doubt, and you are getting a thrombus because of plaque rupture, and of course the patient will present with angina at rest, and there will be a significant flow limitation to that particular area, and there will be surely, in fact, STEMI will produce a transmural infarct, and that is the basis of the basic feature of a STEMI in the first place. And troponin elevation, yes, of course, because there is a significant infarct, and in fact troponin elevation is maximum with STEMI compared to any other disorders which I have been discussing till now. And ECG will be usually abnormal. Very early ECGs can be normal, which is to be noted, but most of the times at the time of presentation, ECG will be abnormal, which can show either this hyperacute T waves, which is a stage 1 of a STEMI evolution of ECG, or they can have ST segment elevation, or even there can be sometimes pathological Q wave formation, which we'll be discussing subsequently. So I think now the characteristic features of all these disorders are clearly understood, and with this I need to finally finish off telling that this unstable angina, NSTEMI and STEMI together will be classified under something called acute coronary syndrome. Why it is called acute coronary syndrome? Because in all these settings the plaque is unstable, and you have to do something urgently to prevent further accumulation of thrombus and complete occlusion of the vessel, resulting in complete infarct. So you have to do something urgently. So that's why all these things are managed in a similar way, like called as an acute coronary syndrome. So acute coronary syndrome can be further divided into NSTEMI, unstable angina complex versus STEMI, which will be discussed subsequently. But before going that, we need to discuss the differences between a chronic stable angina versus a unstable angina in clinical practice. Even before learning the differences between a chronic stable angina versus an unstable angina, it is very, very important to understand the fact that unstable angina terminology has now become completely clinical. Which means, like classic unstable angina, the theory is what is going to confuse the students. What you will be thinking right now after the previous discussion I have made. So unstable angina is something in between a myocardial infarction and a chronic stable angina, which has an unstable plaque with a ruptured plaque and a thrombus formation, but the flow limitation caused by the thrombus and obstruction is not significant enough to cause a infarct, so that the biomarkers will be normal. Classic definition of unstable angina in pathology textbooks. But remember, that has created a tremendous confusion, because we need some terminology to differentiate and tell that the chest pain is not due to chronic stable angina and the chest pain is not a benign chest pain. So that terminology we chose is the unstable angina terminology, which means it's completely clinical as of now. So that is why many guidelines do not use the term unstable angina right now in the ACS. Currently, they split the ACS into two, either an ST segment elevation ACS or a non-ST segment elevation ACS. They no longer use the term unstable angina because it creates a huge confusion, because the term has now become completely clinical. So what you really mean by unstable angina? Any chest pain that is unlikely to be a chronic stable angina or unlikely to be a benign chest pain, which has a high risk of being an acute coronary syndrome, is called as an unstable angina. That's all, which means it's a high risk chest pain. That's all. So it's completely clinical. You now forget the old things that we have learned. Okay, that's only for pathological point of view. So let us start our discussion with the chronic stable angina. So chronic stable angina means the patient should have a chronic chest pain. We know that. So what do you mean by the definition of the word chronic here? So which means the patient should have a history of chest pain at least for 2 months or more. If the pain is there for less than 2 months, it's a new onset chest pain. So that chest pain could evolve into anything. For example, it could evolve into a chronic stable angina over time if it's a stable plaque, or sometimes a new onset chest pain. If it's for less than 2 months, it can be unstable also, which can further evolve into other forms of acute coronary syndrome. So you cannot really predict if the chest pain is less than 2 months. Classically, only if the chest pain is more than 2 months, you can call it as a chronic stable angina from that perspective. On the other hand, the patient's pain in the setting of a chronic stable angina will be completely predictable, which means the patient will have a fixed obstruction, fixed flow limitation, and it will be a predictable pain. In the sense, like if I'm the patient who's suffering from a chronic stable angina, I'll be knowing exactly when I'll be getting the pain. For example, a patient might be getting pain if they climb beyond 2 flights of stairs or they walk beyond 3 blocks in the road. So what I'll be doing, so I'll be stopping just before that climbing 2 flights of stairs, and I'll take rest for some time. Then I'll be moving. So I know exactly at what point I'll get pain, my threshold is, and I'll stop there and I will take rest for some time and I'll start working after that. So this is something extremely predictable. And at the same time, the chest pain, even if it happens, it will be for less than 10 to 20 minutes. It will not be more than that. It's a short duration of chest pain. And apart from that, this chest pain will be exacerbated, we know, by exertion, and it can be relieved with rest and nitrates. Exertion means it's not only a physical exertion, it can be a mental exertion in the form of emotions as well. Typically, the rest or nitrates should relieve the chest pain within 30 seconds to 5 minutes. If short-acting nitrates like nitroglycerin is not able to relieve the chest pain, it's unlikely to be a chronic stable angina. So probably you're dealing with an ACS, so rush to the hospital. So we have seen 3 important features. So one is going to be the chronic chest pain, exacerbated by exertion and emotions and relieved by rest. So out of these 3 features, if you have all 3 out of 3, we are going to call it as a typical angina. If only 2 out of 3 is there, we are going to call it as an atypical angina or atypical chest pain. If none of these features or only one of these 3 features is there, then we'll be typically calling it as a non-cardiac chest pain. The more of which we'll be discussing in the next chapter on differential diagnosis of chest pain. And apart from this, so if you want to really plot how the pain of a chronic stable angina patient will be there, so let me put a graph so that you will understand much better. So on the y-axis, let us take the pain scale, and on the x-axis, let me put the time over a period of time. So when you take a chronic stable angina, the patient will be getting same amount of pain every time. It's a fixed pain. So there is no increase in the pain at all. So every time the patient gets a pain, it will be almost the same amount of pain. And every time it will be associated with some form of exertional stress. So every time there will be some exertional stress or some emotional stress that causes almost a similar type of pain and a similar amount of pain, and of course it will be relieved with rest and nitrates within a span of 30 seconds to 5 minutes, and the chest pain duration will be less than 10 to 20 minutes by definition. And you have to know some anginal equivalents also, because certain patients, like especially those with diabetes or elderly patients, may not manifest all these symptoms which I told very clearly. So they cannot manifest chest pain, but they will manifest something else like dyspnea, fatigue, or dizziness, which is also referred to as pre-syncope. So these are basically considered as anginal equivalents. Okay. So now what is unstable angina? Unstable angina, simply speaking from clinical point of view, it's an high-risk chest pain. That's all. So we know chronic stable angina can never have chest pain at rest. So typically, a high-risk chest pain, that is an unstable angina by definition, is going to have a chest pain at rest. As simple as that. Which is a very, very high-risk feature, a resting angina. And of course, the patient with the chronic stable angina will be having history for more than 2 months as per the definition, but in a setting of high-risk chest pain, that is unstable angina, patient will be having a new onset chest pain that is less than 1 to 2 months history. That's called a new onset chest pain. And why new onset chest pain is a high-risk feature? First of all, we have to understand why chronic stable angina, which is a low risk, is having history of more than 2 months. The patient presents a little late, or patients will have a chronic history because, they know how to get rid of that pain, and the pain is very predictable. So that's why they have a long history. But why this patient should come early, within 1 to 2 months, and why it is considered as a high risk? Because the patient, first of all, presents early because it could be a severe chest pain. That is a high risk, which means severe chest pain is defined as CCS grading 3 and 4. What is CCS? Canadian Cardiovascular Society grading. 3 and 4 is a severe chest pain. So the Canadian Cardiovascular Society grading we'll be discussing in the next chapter. And apart from that, the pain would have become unpredictable. That's why they are presenting very early, within the first 1 to 2 months. So unpredictable chest pain, like getting chest pain at rest, or probably having an increasing chest pain over a period of time, or the patient is getting chest pain when they are not expecting a chest pain to happen. So these are the things that are basically high risk features. That's why it's coming under high risk chest pain. That is nothing but unstable angina. Apart from that, patients might have an accelerated angina or accelerated chest pain, otherwise referred to as a crescendo angina. So what do you mean by crescendo angina? It's exactly opposite to the graph that we have seen some time back for chronic stable angina. So let me draw another graph here. So over time and the pain scale on y-axis. So what is an accelerated angina or a crescendo angina? The pain will increase in severity and duration over a period of time. So which means some of the pains can be happening at exertion, that doesn't matter. Some of the pains can happen at rest. So it could be a rest pain, or it could be a chest pain that is associated with exertion as well. But the most important fact to tell it's a crescendo angina is it keeps on increasing over a period of time. So it is no longer behaving like a chronic stable angina. It's not a fixed and a predictable pain anymore. It's getting unpredictable, and it's getting more severe, and it's getting more frequent than what they used to get before. So this is an unstable feature. So this is a high risk feature. That's why you're keeping it under unstable angina. So a patient who's having a chronic stable angina moving into an unstable angina, this graph will be extremely useful. So getting a rest pain or getting more pain and unpredictable pains, very, very important high risk feature. And apart from that, a prolonged chest pain is very, very important, especially if it is more than 20 minutes, is a high risk feature. Especially if it's of ischemic type, you have to be very, very serious about it. And number 5, it's not given in the textbooks, but it's very, very important, nitrate resistance. Whenever the patient was supposed to respond to nitrates previously, now becoming increasingly nitrate resistant, and their pain is not getting resolved with nitrates, rush to the hospital because it could be an acute coronary syndrome. One of the important features of ACS is short-acting nitrate resistance, that is NTG resistance. So all these features which I have told you are characteristic features of a high-risk chest pain. Currently, high-risk chest pain is what we refer to as unstable angina, and it's a clinical term. That's why I'm telling multiple times. So now we have a separate classification system for unstable angina. That is the Braunwald classification system for unstable angina. So we have to understand this Braunwald classification in the form of a table so that it will be easier. So on the y-axis, I'm going to write the clinical features of the chest pain. So class 1 means the patient will be having a new onset chest pain. So why the patient comes to the hospital within a short span of time? Because it is severe, which is defined as CCS grading 3 and 4, or the patient might be having an accelerated chest pain, which means either they are becoming crescendo or they might be becoming unpredictable. But remember, in the clinical classification 1, there is no rest pain. That's all. That's a very important point. If the patient has rest pain, then they will come under 2 or 3. So resting pain, that is subacute in nature, which is defined as pain history more than 48 hours. Beyond 48 hours, not within the last 48 hours, but within the last 1 month. So it means there's no pain in the last 48 hours. Before 48 hours, they had a pain, but in the last 1 month. So that's what we refer to as subacute. Class 3 means patient is having a rest pain that is acute in nature, which means within the last 48 hours, they had rest pain. Simple. And on the x-axis, I can write classification system A, which is called as secondary unstable angina. So why we call it as a secondary unstable angina, which means there is some other reason to explain the patient's chest pain. Definitely not a non-cardiac type, it's a cardiac reason only. For example, the patient might be having severe anemia to explain the chest pain. The patient might be having tachycardia continuously to explain the chest pain. The patient might be having high BP to explain that chest pain, or the patient might be having left ventricular hypertrophy to explain the chest pain. So if you have some explainable feature, so that will come under category A. And category B, it's a primary unstable angina, which means there is no other explanation or no other secondary cause for the chest pain. It must be an atherosclerotic plaque. That's what it means. And category C means it's a post-infarction unstable angina. After myocardial infarction, the patient can get chest pain again, which can be unstable in nature, which might even tell you a reinfarction. There are a lot of causes for post-infarction angina, but one of the reasons is reinfarction or a recurrent infarction. Of course, new onset severe chest pain that is having a secondary cause will be under class 1A. New onset chest pain that is not having a secondary cause but primary in nature will be put under class 1B. And the new onset severe chest pain that is happening post-infarction will be put under class 1C. And the subacute rest pain with a secondary cause will be called as class 2A, and subacute rest pain with no secondary cause and a primary cause will be put under class 2B, and subacute rest pain that is happening in the post-infarction period will be put under class 2C. And similarly, an acute rest pain that is happening due to some secondary cause will be under class 3A, and acute rest pain that is happening without any secondary cause, and if it's primary, it's put under class 3B, and acute rest pain, if it's happening in the post-infarction period, it will be called as class 3C. And apart from that, there is a new addition by ACHA to the Braunwald classification that is called as post-revascularization angina. That can happen after a PCI or a coronary artery bypass grafting. It can be either peri-procedural, which typically happens within 48 hours of doing that particular procedure, or it can be late in nature, happening beyond 30 days as well. Finally, we need to discuss on the classification of acute coronary syndrome. And of course, we know ACS is divided into something called a STEMI and a NSTEMI unstable angina complex, but I'm not going to use that term. I'm going to use a different term, which is the correct terminology, that is ST-ACS, that is ST segment elevation acute coronary syndrome, and NST-ACS, that is non-ST segment elevation acute coronary syndrome. Previously, this is what we have been calling it as NSTEMI unstable angina complex, even though these terminologies are still used interchangeably. But you have to understand that unstable angina terminology is more clinical, so using it in the setting of ACS might actually give rise to a lot of confusion. So don't really use it. High risk chest pains clinically is what we refer to as unstable angina. So the pathological definitions of unstable angina has no real implications in real life, because NSTEMI and unstable angina both will be treated in a very similar manner. So let us stick on to the term NST-ACS. So what is the basic difference between these two? So one particular image which I'm going to show can help you identify what's really happening here. So if you're able to tell, it'll be very easy for me. So what is the image showing here? So both these are showing a thrombus. So there's no doubt about that. So this thrombus that is seen in the setting of ST-ACS is showing a complete occlusion, which means it's almost 100% occlusion. And there are other features of this thrombus, which means it usually involves a single vessel, ST-ACS, even though there are multi-vessel STEMI also, but usually STEMI involves a single vessel. And most of the times, they'll be having an acute and a dramatic presentation, and the occlusion will happen dramatically and acutely within a short period of time, within hours usually. And that's why they don't have any time to develop the collaterals. And coupled with that, they will be having lesser amount of comorbidities, even though these terms are highly variable in patients. But these are classic and traditional terms, less comorbidities in the setting of STEMI. On the other hand, the thrombus in NST-ACS is more subtotal, which means it's not a complete occlusion at all. You can see a lot of lumen that is left, which is shown in the pointer right now. So which means it's a subtotal occlusion. It's never a total occlusion. At the same time, this thrombus is also going to produce something called a phasic distal embolization. That really matters. So subtotal occlusion with phasic distal embolization is the classic word that you have to know for a NST-ACS. Apart from that, differentiating from a STEMI, NST-ACS tends to be more subacute in nature, not be acute. So you have little time to develop the collateral. So they're going to have more collaterals in this perspective. And apart from that, these patients tend to have relatively more comorbidities compared to that of the STEMI patient, which means they might be having diabetes, hypertension, dyslipidemia, then smoking. So much of other comorbidities may be there. And apart from that, these patients will typically have a multi-vessel disease. So a lot of differences between them. And finally, what are the implications of this? That's what we want. So what are the implications of whatever we have seen till now? So I'm going to use the same image that I've used for coronary blood flow diagram and coronary blood flow understanding. So this is the same image I'm going to use throughout the cardiology as well. So as far as the STEMI is concerned, it's a single vessel, 100% occlusion, and it's very acute, and there's no time for the formation of collaterals. So all these things will come on to a point where STEMI is going to show a focal and a transmural infarct. So what do you mean by that? So why it's focal? Because it's a single vessel disease most often, and there is no phasic distal embolization like that of an NSTSCS. So usually it involves that one particular vessel territory. So it's a focal infarct. And it's transmural. Why? Because it's having less collaterals and it's a full occlusion, 100% occlusion. They produce a full thickness, full wall thickness infarct in that particular area. So it's a focal transmural infarct. On the other hand, NSTSCS patients might be having multifocal and subendocardial infarcts. So we know subendocardial portion is the most vulnerable portion for ischemia. So if it's not a total occlusion, the subendocardial portion is the one that's going to go for infarct. At the same time, why it is multifocal? Because of two reasons. One, they are having multivessel involvement, and at the same time, they are having phasic distal embolization, which can produce shower of embolus to different areas, producing multifocal infarction. All right. So what are the implications of these now? So we have to see the ECG findings now. So what the ECG is going to show? So this is what you're going to get in the setting of a STEMI or a ST-ACS. So what is this basically? It's nothing but an ST elevation that you're seeing. So why do you get ST elevation? These ST elevation are actually basically due to injury currents that are produced from the transmurally infarcted myocardium. So these are due to injury currents. And at the same time, another significant feature is the development of the Q waves. That's why this type of ST elevation ACS or STEMI is also referred to as a Q wave MI. Q wave myocardial infarction. Why do you develop a Q wave? That is due to death of the myocardium. Remember, just simple transmural infarction without death will produce only ST elevation, but transmural infarction with death will result in the development of Q waves, the mechanisms of which will be discussed subsequently in the ECG chapters. So you can get a Q wave with a STEMI with a high frequency in fact. So what you're going to get in the setting of a NSTSCS. So in NSTSCS, you are typically going to get something like this. You will be basically getting a ST segment depression or probably even a T wave inversion. So anything can happen. So ST segment depression with an upper T wave is the most common finding, but what are the ways of presentation we'll be discussing subsequently in the ECG section. But this is very classical, that is ST segment depression, especially a downsloping depression or a horizontal depression is going to have a lot of significance, which we'll be discussing subsequently once again in the ECG chapters. Remember, ST elevations can be localized. And you can understand by a hint that since the transmural infarcts are usually focal and they can be localized, the ST elevations that are coming from that local areas, focal areas, can also be localized. On the other hand, these ST depressions and T wave inversions cannot be localized. And for example, if you have only ST depression in 2-3 AV, you cannot tell that the patient is having inferior wall NSTSCS. So it cannot be localized. That's very, very important. Cannot be localized. And when the ST depressions are very, very significant, especially if the ST depressions are present in V4, V5, V6, these are the leads that are supposed to have a significant ST depression or that are supposed to be significant in the first place. If you have ST depressions and T wave inversions in 2-3 AVF that are mostly non-significant, especially if you see in only one lead, but if you see in V4, V5, V6, ST depression, that becomes really, really significant. But anyways, so finally, final nutshell, you have ST-ACS typically evolves to produce a Q wave myocardial infarction, and NST-ACS typically evolves to produce a non-Q wave myocardial infarction. Suppose if a patient with ST-ACS have been treated very, very faster and you have reperfused, then they might become a non-Q wave myocardial infarction as well. Suppose if the patient with NST-ACS have not been treated at all, then the thrombus might expand over a period of time, can produce a full thickness infarct and they can produce a transmural infection and they can evolve into a QAMI. Which means most often STACs will produce a QAMI, but it's not always the rule. Most often NSTACs will produce a non-QA myocardial infarction, and once again, it's not always a hard and fast rule. And what about the troponins? Troponin levels definitely elevated, as I told you before, and there will be a serious elevation in the setting of a STACs because it's a full thickness, complete infarct. Whereas in the setting of a NSTACs, troponin elevation can happen or troponins can be normal as well. This is a very important thing. So previously, we have distinguished NSTEMI and unstable angina pathologically and clinically based on the troponin values only. Troponin values are elevated, we call it as NSTEMI. If the troponin values are normal, we call it as unstable angina. But remember, currently these troponin elevations are not used to classify in the first place because those classification systems are absurd and it's going to only create a lot of confusion. So leave all those things. So if the troponin is elevated, it indicates more severity and a poor prognosis. That's all, irrespective of whether it's a STEMI or irrespective of whether it's a NSTEMI, unstable angina, or irrespective of whether there is some other cardiac disorder. Elevated troponin is always a high risk. You have to always note that. So elevated troponins means it is having some problem in the heart. That's all. So ischemic troponin elevation is what we refer to as myocardial infarction. But anyway, it's fine. So that doesn't really matter as of now because it's not going to change the treatment as well. You're going to treat NSTEMI and unstable angina in the same way. That's all. So finally, going on to the type of the clot that you're going to develop in the setting of a STEMI is a fibrin clot. So that is why fibrinolysis is very, very effective, especially if you do within the first 2 to 3 hours. Fibrinolysis is going to be extremely effective in breaking the clot because it's made of fibrin. Once it's organized, it's difficult to break as the time goes on. But it is subacute in nature, where the fibrin would have washed away by autofibrinolysis because that is happening in the body. So they will be more of a white clot. So they will be containing more of platelets compared to the fibrin. So that's the reason why I can call this STEMI clots as red clots and NSTEMI clots as white clots, even though gross appearance will not be exactly like what we are describing in technical terms. So what are the goals of therapy? So what do you have to do in the setting of a STEMI? It's a full occlusion, 100% occlusion. So you have to try to reperfuse as soon as possible, which means you have to open up the vessel through some form of revascularization like fibrinolysis or a PCI, and you have to reduce the infarct size. Remember, infarct does not necessarily mean the myocardium is dead. It is still suffering on the verge of death. If you reperfuse very, very faster, within the first 30 minutes or 1 hour, there is a lot of chance that you can escape even without any infarction. So to reduce the infarct size, that's one of the primary goals of treating a STEMI. And third is to reduce the complications, because STEMI is associated with more in-hospital complications compared to NSTEMI and unstable angina complex, and you have to increase the survival of the patient. These are the goals. And to achieve these goals, the primary modality we are going to use is something called a reperfusion. There are 2 ways of reperfusion. One is the thrombolysis, which is highly effective in STEMI because it's an acute clot, more of fibrin, so you can easily break down, especially if you do in the first 2 to 3 hours, it's highly, highly effective. But even though the window period is up to 12 hours, which we'll be discussing subsequently, but it's better to do as early as possible within the first 2 to 3 hours. Second mode of reperfusion, which is the gold standard mode of reperfusion, is primary PCI. That is percutaneous coronary intervention, which is done on a primary basis as a first line therapy. That's the best one. If the thrombolysis has failed, we'll go for rescue PCI, which we'll be discussing subsequently, but either PCI or lysis, these are the modes of reperfusion. That's what we're going to do. And whether you will use GP2B3A inhibitors or not, GP2B inhibitors are not that effective in the setting of a STEMI patient. It's not used typically in STEMI patients unless you are taking for a PCI, unless PCI is done. So before, as a preparation for PCI, you can give a GP2B3 inhibitor, but GP2B3 inhibitor as such as a treatment option for a STEMI is not that helpful because GP2B3 inhibitors, we have discussed in hematology, are basically antiplatelet agents. They're going to be anti-aggregating agents. So this is more of a fibrin clot, less platelets, more fibrin. So they're not that helpful unless and until you take the patient for a PCI, where it is given before the PCI as a prophylactic basis. And echocardiogram, on the other hand, typically shows a new regional wall motion abnormality, which is extremely common. They'll show a new RWMA, that's a regional wall motion abnormality. What do you mean by that? So if one particular area of the myocardium is infarcted, that area may not contract properly and it might show hypokinesia or akinesia. That's what we refer to as a new regional wall motion abnormality. Existing will not come under an MI or could be due to old MI, but new means it's an acute MI. And what are the goals of therapy in the setting of NSTACS? Here the goals of therapy is to reduce the thrombus progression because the thrombus has not completely occluded the vessel. So you have to reduce the thrombus progression here. And at the same time, you have to reduce the distal embolization that is happening. And you have to prevent recurrent ischemia. Because most of the NSTACS patients will be having multivessel disease. So you have to prevent recurrent ischemia. So for this, you can use anticoagulation as a mainstay. Like for example, you can use heparins. And the heparin of choice is of course the low molecular heparin, which is having strongest evidence, which we'll be discussing subsequently. Or you can use GP2B3A inhibitors. And GP2B3 inhibitors are really helpful whether you do PCA or not in the setting of NSTACS because it's more of a platelet clot and anti-aggregating agents. Antiplatelet agents like GP2B3 inhibitors are very helpful in this setting. That's why. And heparins we use because we need to reduce the thrombus progression and we have to prevent the phasic distal embolization. That's why we are using heparins in this setting. And apart from that, you need to do a coronary angiography. I'm not telling you should necessarily do a PCA, but it's important to do a coronary angiogram sometime, depending on the risk, which we'll be discussing subsequently in the NSTACS chapter. So you have to do a coronary angiogram to assess the coronary vessel status or a coronary artery status. Similarly, echocardiogram in the setting of NSTACS may be completely variable. It can be completely normal or can show global dyskinesia or global dysfunction because it's multifocal embolic infarcts at multiple different places. So they might have a global dysfunction of the heart, or very rarely they might show a regional wall motion abnormality also. So it's highly variable in the setting of a NSTACS. And finally, is there any mortality difference between them, which is a very important point as well. So when you take the mortality, we can split into something called as an early mortality and a late mortality. Early mortality, we take mortality at 30 days after the event, and late mortality means after 1 year from the event. Early mortality, usually STACS generally tends to have more early mortality compared to that of NSTACS, where if you want to know the absolute values, STACS generally tends to produce early mortality of 3 to 8%, whereas NSTACS tend to have an early mortality of 2 to 4%. Even though with the advanced therapeutic options, the mortality is almost similar between the two. But anyways, traditionally speaking, the early mortality of STEMI is more than that of the NSTACS. Late mortality, on the other hand, STEMI and NSTACS tend to have almost equal amount of mortality. There is no much significant difference in the late mortalities after 1 year. Both tends to show similar mortalities, means both are going to kill you. And STEMI is going to kill more early, and in the later period, both can kill you after 1 year. On the other hand, if you take about the overall mortality of acute coronary syndrome, the early mortality will be 2 to 3%. Suppose if you exclude unstable angina from your basic clinical picture, then you'll be having 5% as the early mortality rate. And the late mortality typically is around 5 to 9% overall. So this is the number that you have to know. This is the overall mortality. Overall early mortality is 2 to 3% and overall late mortality is approximately 5 to 9%. So let us summarize. So what are things that are happening in STEMI and NSTACS? In STACS, the presentation is more acute. It's usually involving a single vessel and it's going to cause 100% occlusion, so that you will have a focal and a transmural infarct, which is going to produce ST elevation. If you don't treat in time, they can progress to Q wave formation, resulting in a Q wave MI. And more of a fibrin clot, patient will have a lesser comorbidities. So the goals is going to open up the vessel because it's completely occluded. So opening up can be done with the help of lysis or PCA, where PCA is going to be the preferred option. and early mortality is more in the setting of ST-ACS compared to that of NST-ACS, and echo is definitely going to show a regional wall motion abnormality. Whereas in the setting of NST-ACS, you are going to have a subtotal occlusion with phasic distal embolization, very, very important point. Apart from that, the patients might be having a subacute presentation. The thrombus will be building up over a period of time. And the patients will be having a subendocardial and a multifocal infarct as a result of this phasic distal embolization and a subtotal occlusion. They'll not be producing a transmural infarction. So more of, they'll be having a ST depressions and T-wave inversions. So STD changes will be there, not ST elevation. And usually they won't progress to a Q-wave formation unless until you don't treat it at all, they can progress to Q-wave. Usually with treatment, they don't progress to Q-wave formation. And apart from that, echo may be completely variable in this setting. And the goals of treatment is to reduce the thrombus progression and to prevent the phasic distal embolization. That's why you are giving your anticoagulation and GP2B3 inhibitors, which are very effective in the setting of NST-ACS. And as far as the troponins is concerned, it will be definitely elevated in the setting of STEMI and will be maximally elevated. In the setting of NST-ACS, you may or may not have a troponin elevation, but troponin elevation, if it's there, irrespective of the cardiac condition, it means there is some severe condition going on and it's a poor prognostic scenario. Mortality wise, STEMI, early mortality more compared to the non-STEMI, and late mortality is almost equal between ST-ACS and NST-ACS. So with this, I think we can complete this particular chapter. This is a basic introductory chapter to cardiovascular system and the ischemic heart disease. So from the next chapter on, we'll be discussing in depth about each and every different diseases and probably their investigatory aspects as well. So let us go to the next topic. Thank you.